Hello, and thank you so much for joining us today for the webinar Your Lift to a Better Augmentation. It is a great pleasure to introduce to you Dr. Marcus Engelschalk, whose aim during this presentation will be to discuss about understanding success factors of different sinus floor elevation techniques and implementing them in everyday practice. Dr. Engelschalk began practicing dentistry in 2000 in Munich after finishing university studies and taking several specialized courses in oral surgery and implantology. In 2002, he became attending doctor in the famous Arabella Clinic in Munich. As a consequence, his treatment spectrum was expanded to complex surgeries and oral rehabilitations under total anesthesia. He advanced in his techniques even more after finishing the Masters of Science in Laser Dentistry at RWTH University in Aachen, Germany. Dr. Engelschalk has published scientific and clinic reports and giving lectures in the topics of implant dentistry and laser therapy in national and international journals and meetings. He actively participates as an editorial member of an implantology journal and belongs to the scientific board of different implant systems. We would like to thank Dr. Engelschalk for being with us today and KaVo Academy for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Engelschalk at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Engelschalk.
So, hello, I want to give you a warm welcome to our today's webinar about the lift. The sinus lift, the survey, comparison and evaluation of the current methods. Well, our overviews and topics of today, very easy, very clear. First of all, we will see imaging methods of the sinus diagnostic, the overview of different methods of the internal sinus floor elevation, compared a little bit to the external sinus floor elevation. Then the question, what causes the difficulties and traumatisms of the internal methods? I think this is very important for us today. And what is the consistency? So what can we do if we see some problems? How can we solve them? Then we should go into the internal sinus lift, because it's not so easy on the first view to control the internal sinus lift. And then at the end, as already mentioned, question and discussions. So let's start with diagnostic. First of all, I don't want to lecture today about the X-ray topics in deep, but I want to give you some information about the things we do for the internal sinus floor elevation. The thing is, during an X-ray examination, we have to know what we want to find or what we want to see if we do the X-ray. Well, first of all, it's very important to know about the anatomy of the sinus. Well, the form of the sinus, we already know it's based at the lateral nasal wall. So we see the whole structure of the sinus, and its volume depends on the patient size. But we have to know that it's a very big area for us to treat. The anterior expansion can be until the first premolar or distal to the canine. This is very important to know, because sometimes the sinus creates small pockets at the region of the first premolar. And if you want to lift, doesn't matter if you do the external or internal sinus lift, you have to be very precise to remove the membrane from the bone there. Sometimes it's difficult to see. And I think the most important thing for the anatomy is that we have a mucosal thickness of around 1 millimeter. This is very, very thin. So if we treat this mucosa, we have to be very careful, because 1 millimeter is very thin. We'll see if it's better to have a thicker membrane or not. Thicker membrane will be created by some chronic diseases of the sinus. This is very important to know. What can we expect if we have a look on the bone on the X-ray of the sinus around? Well, another thing is the anatomy is not only bone, it's soft tissue, and it's something about vascularization. So it's important to know where is the blood flow coming from and what do I disturb if I cut or drill a hole into the bone around the sinus. And if we see there is arteria anonyma, it's around 2 centimeters above the alveolar ridge. It went from behind to the front, and this is often the arteria we cut if we create the lateral window. And this is the reason why sometimes the hematoma because you cut this arteria. It's not so common, it's not so well known, but it exists. And the second thing, which is a bony structure, which is very, very important if you perform the sinus lift, doesn't matter external or internal, are the so-called underbud septums. These are little bony warts going through in the middle or at the beginning of a sinus, and they divided sometimes the sinus in different parts, mostly in 2 parts, and then you have to perform 2 separate sinus floor elevations to create an augmentation. This is very important to know before you start your can have a big influence on your planning of your operation. Well, we know pneumatization will become more after tooth extraction because we have a bone loss. So we fight against the bone loss by extraction or with the age of the patient. So often we can augment bone at the apical side of an implant structure, but at the coronal side there is still a bone loss and we have a very long length of the crown. This is something you have to keep in mind if you're planning the numbers of implants and if you're planning the amount of augmentation. Well, if you do the X-ray, doesn't matter which kind of X-ray you do at the beginning, but if you do the X-ray, what can we see? What can we expect to see? Well, there are, of course, bony structures. We see hyperdense reaction, swelling or growth of volume of bone. We see lytic reaction, means the bone is shrinking, or we see some mixed reaction of the bone. Depends what happened to the bone at the region where you want to perform your sinus lift. And of course, we have the soft tissue. We have the swelling of the tissue. We have sometimes some liquid in the sinus. This is very important to see. But the problem is an X-ray always shows us better the bony structure than the soft tissue structures. And this is a point if you are planning to do X-ray control during your operation, during your internal sinus floor elevation. Just beware that you can only see the bony structure, you can see the amount of augmentation if it's radiological seen or the implant, but you won't see any perforation of the membrane. If you hurt the membrane very small, with a tiny hole, you won't see it on the X-ray during the operation. So it's important, and this is a topic we will discuss later on, to have some control mechanism during your operation or at the end of your operation to be sure that you won't hurt your membrane too much. Well, imaging methods are very clear. If you're performing the external sinus floor elevation, it's very easy because you mostly have it and you can see what you're doing. If you do it in the internal way, it's more difficult because the entrance to the sinus is very, very small because we choose this way of minimal invasive therapy. So what can we see? And it's better not to work in the controlled vision about what you can expect. So in this case, mostly we recommend some cone beam X-rays because we want to see these structures. And on this picture you can see meteor from the molar in the sinus. You can see some septums, and I think this is very important. If you we just want to augment the area of the first molar or the second premolar, so it's not that problem because the second molar would be missing and you would plan to create a sinus for elevation there too. Then you have to perform a second sinus floor elevation with a second entrance. This is very important. Even if you perform an open window technique, then you have to create two windows because otherwise the membrane wouldn't be lifted. This is important to see, and here's a more detailed picture from the cone beam scan. And this is what I told you. Now you can see the red line I marked for you, that now we have a clearly picture of what we can expect. And if you look on the right side on the survey of the head of the maxilla, then you can imagine this cut that there is a septum. And it's very, very important to know what you can expect with these septums. Just a short information, if you do this cone beam, this is depends on the window you want to see. So you can do this with your X-ray very, very clearly, so that you only see what you want to have. Well, first we saw the septums. Now what can we see on these kinds of it's the same cone beam on this side? Well, it's very easy because we can measure now the height of the residual bone. So this is important to decide, will it perform implant placement and augmentation at the same time, or should the bone or the augmentation heal at first and then you bring your implant in? This is very important information for you as well as for your patient, because for the patient means that he has to come for a second operation too. And for you it's very important because you have to choose the kind of implant you will using, the form of implant. Well, it can change if you use a simultaneous sinus floor elevation in combination with the implant, or if there is enough bone and you just have to place your implant. So this is the second information we can have from this cone beam scan, that we see there is enough bone and we can bring in the implant and the augmentation. Well, maybe you right now, your first question, what is the height of bone I need to place an implant simultaneous to? I would recommend not less than 4 millimeters. I learned 5 millimeters. Well, the daily experience learned me that we can perform it with 4 millimeters. If you will be on the safe side, just take 5 millimeters as a residual bone. We need the bone to give us a primary stability to the implant in this area. With a bone augmentation in the sinus floor, well, there won't be a healing. So the implant fixed and tight, and then the augmentation will heal together with the implant. Otherwise, you will lose them all. So I would say 5 millimeters. Well, there's a second reason why we need 5 millimeters, but I will tell you later. So there's another cone beam picture, and this gives us time for another reason why we can use this. So if you see the cut now, we see from the buccal to the palatal side of the bone, and we see the height of the bone, and I marked it for you now. Now we can plan the implants, and we can plan our bone augmentation amount we need. And I told you we can plan. So this is a picture. If you transfer these cone beams data into a surgical planning software, then you can position the implants right before you do the real operation. Now you can position the implants, you can plan the implants, and you can see how many bone do I need Most of the most mistakes they've been done by the external sinus floor elevation I saw in my education, they've been that you created your window, you tried to remove the membrane, but you didn't enough to the palatal side. If you don't feel the palatal bone with your instrument after having removed, you're not on the normal X-ray. You see, well, there's bone in the height, but you don't know is it deep enough. And if you place your implant and it's just covered half by a bone and the rest is the sinus floor, you will never see it on the two-dimensional X-ray. So it's very important to elevate the whole sinus you want. So this we see the need for the implants, we see the need for the augmentation, and we can see on the patient's right side, we can see the septum. And this is also very important. If you try to drill an implant through a septum, I think won't be before or behind the septum, but never drill into a septum because it's quite cortical, it's bone, and it's very, very hard. So another picture from the same case. You see the implants, the needed amount of the bone or the sinus floor elevation, and this gives us more help, more good feelings if you start your implantation or your operation or your augmentation. Otherwise, you would start and say, well, patient, let us see what we can reach. And this is not the surgery of today, I would say. Okay, coming back from the X-rays now, what do we have for different methods at the moment for the internal sinus floor elevation? There are different methods, and just check it. Well, the aim of the internal sinus floor elevation is very clear. It's the elevation of the Schneiderian membrane without any damage to the membrane, any damage to the bone, any perforation, and we won't have a lateral access window. So we want to avoid invasive. And often it's combined with a big swelling for the patient and the shrinkage of the gingiva. You have to create bigger flaps. You have to use artificial membranes to cover the window, and it's not so easy. So criteria for the internal sinus floor elevation, if we look at the aim, so it should be minimal invasive for soft and hard tissue. That means the traumatization is low. A safe first entry into the sinus without any perforation. So you will hear this word safe. What does it mean? It doesn't mean the safe entry into the sinus through the membrane, through the Schneiderian membrane. I think safe first entry means that it's this safe entry through the bone underneath the membrane. So this means the first contact is very safe and very predictable for you, because this is very dangerous for the mistakes we can do. So it should be easy to perform. Significant elevation of the sinus membrane should be possible. That means if you do an augmentation, sometimes, as we've seen in the picture before, in the X-ray before, sometimes we want to augment more than 5, 6, 8 millimeters of height. Until today, it's not elevation methods to lift these big heights. I will show you a way how we can do this. But if you use just your osteotome, then only 1, 2, 3 millimeter at maximum to elevate, just to push back the bone and the membrane to bring in your implant. But it's not in the way we do it with a lateral access window. Well, and the intraoperative control should be very clear back system to know if the membrane is still okay or do we have ruined it already. So this is very important. Yeah? And for the internal sinus floor elevation techniques we have on the market. So let's see, what do we have? We all know the open window technique by KaVo. Look, it's very old. It's good. It's effective, but it's a traumatization. And then we have the internal close approach. So on the one hand, we use some sharps, some drills. We can use the piezo surgery. It gives us more secure feeling for touching the membranes. And we know surgery you can use a laser, especially for treatment of the bone. This is a completely different laser than laser surgery for treatment of the soft tissue. So you can select a little bit. On the other hand, we do know the osteotome and the balloon technique, and we also know drill and hydraulic pressure. So you elevate. And doesn't matter what you choose or if you are inventing a new method, it's very important. We need to be invasive for the bone and soft tissue and therefore less invasive for the patient. It's not important to elevate the sinus floor and to bring the implant in at the same time if it's not possible, because this depends on the residual bone height as we discussed already. This is given by the anatomy of the patient or the defect of the patient. But if you perform sinus floor elevation, it's very, very important to be less invasive for the patient. Well, just give you an overview with pictures what I mentioned the slide before. Well, this is a picture for the internal sinus elevation we learned by Professor Summers. It's very easy. I think it's the first way we try to do it. We just drilled a little hole and then we bring our osteotomes in. We crack the residual bone and we just pump up the membrane, the sinus membrane. And you can do this by filling the drilling chamber with augmentation material and bring this up. And what I learned, still can remember his words, was never touch the sinus with the instrument. I think this is very important, that you just bring in the augmentation material to lift the membrane. But in this case, well, it's not a good control. It's not a good visual control. We don't have any visual control. We just have the feelings. And the problem is that you're not able to lift as much as you like sometimes. Then there was a new technique using a balloon for not having a big traumatization for the membrane. But at the end, you see there is still a slight bony part you have to push with the membrane apically. This can work, but sometimes we just want to lift for one implant. Sometimes we have to lift for 3 implants, and then problems will begin. Another type of possibility is to use a drill. It's a self-stopping drill, but you can see it very good. You see the drill is at the niveau of the Schneiderian membrane, and there is a very sharp edged part of a bone between the drill and between the membrane. So it should work, but it's very, very difficult not to cut the membrane by the sharp edges of the part of the bone you push into the sinus. So it all works, but thing where you use a drill and you try to push the membrane back by using some liquid. normally okay, but remember I told you never touch the sinus with an instrument, and if you look at this picture, well, it's quite difficult not to touch if you see the drill. And there's a new method is it's working with high hydraulic pressure in combination with the burr to elevate the sinus floor augmentation. So let us combine all this information into this slide. I didn't translate everything from German into English, but I think you can read the information we need. At first, we want to select the information: minimal invasive, safe entry. You remember I told you the safe first entry in contact with the membrane, not disturbing the membrane. Significant elevation is the question about how many bone height can we gain, and the feedback system. Feedback system is if we see it, if we can hear it, if we can feel it, or if there is anything else. So let's see. The classical lift is the first we want to compare. Then we have sinus balloon lift and the osteotome technique. Then we have the hatch streamer. It's the burr which stops by itself. Then we have sinus condensing and the so-called YEDA system. It was the last thing I showed you with the combination of high hydraulic pressure and the burr. So the classical sinus lift is not minimal invasive. In this case, it's a maximal invasive thing we can pick. Well, the osteotome technique or the sinus lift with the balloon is something in between, because you have to drill a hole, then you have to crack the residual bone, and then you bring in the balloon. Cracking is a little bit a problem, and what we say for you is if you do the osteotome technique, then you have to tap on the instrument. And believe me, I have an implant by myself performed with the osteotome technique. You will hear it through the whole head because it's a very strong noise you can recognize. The rest should be very minimal invasive because the entrance to the operation site is very small. You just cut on the alveolar ridge and you will go through a small hole, mainly the diameter of 2 or 3 millimeters, where you have the entrance through the bone into the sinus. Well, the question is, minimal invasive is very important for the patient, for the healing period, for the time after the operation. But for us, more interesting is safe entry and significant elevation. Well, it's clearly that the safe entry, it's not a real safe entry because you have a huge area where you want to have a lift from the sinus membrane, because you have to create your window. Significant elevation, for sure, you will have because you can lift the membrane if you're able to you can augment as big you want. Well, safe entry is a problem for osteotome and balloon because there is a fracture of the residual bone, the osteotomes, and you just can open or elevate the bone by fracture it. And these sharpening edge are the problems for this technique. The head streamer, it depends on the anatomy of the patient, because if you have a so-called underwood septum right underneath the septum, well, most of these techniques are depending on the capability of the dentist or of the surgeon who's performing the operation. And well, if you look at significant elevation, you see the balloon lift and the REMA technique too much height. And this is a problem because we can just use the internal way or the minimal invasive way for lifting, then it's again no problem, but the indication for this technique will shrink in your office. And now the most interesting part in my operating system. Well, you have a clear feedback if you have the classical window, because you can see it. If you have no feedback, then you will have the feedback at the end of the healing period or during the healing period if the patient gets an infection or not. And this is a way too late, I would say. The classical window technique is at the Jeder system because it's a pump, it's a drill, and we will explain it later on the slides, where you can see pressure, and the pressure gives you a feedback on the membrane. We will see it in some slides later on. So if we see this comparison, and we see the possibilities we have, so what causes the difficulties and the traumatisms for these methods? Well, it's very clear to see. If you define your problem, basically we can say relatively uncontrolled proceeding and limited overview. This is for every method. Well, external, we have the opening of the lateral sinus. We have the complication on top for the flap, for the using a membrane, for the thing, or the internal way. We have the problems of an uncontrolled lift, and we don't have any feedback system and limit. So there should be something else. Here you can see a window we created with a burr. It's okay, but it's invasive. You see on the mesial cut, we never cut on the distal side because the blood vessels will come from the distal side and give the flap a little nutrition. So this is very important. Nutrition also plays a big role in creating the flap. So if you see these colored pictures now, you see I marked it with a blue line, the flap. It's the size of the flap. You see the window. You see bringing in the implant, bringing in the augmentation material. It's more than one miracle at one time you have to perform for the patient. But it's still working. This is the same access, but we use the piezo to create the window to be able to not to hurt the membrane. So if you have a look on the colored picture, then you see the same. It's the same like before. We just use the piezo instead of the burr or the drill. Give us more safe trans lift. We have to cut, and it's very invasive. So if you look at this picture, it's in this case automatic, but maybe you bring in the balloon afterwards, you bring in the hydraulic pressure. You see the axis is very small. You see we just cut it on the alveolar ridge and drilled a little hole, and then we bring in our instrument. So there's no flap as we performed on the examples before. There's a small flap for the entrance, and then you can perform your implantation or your augmentation very easily. But there's no feedback system. You never know if you're successful or not. And remember, I told you on the X-ray, you will not burn. Or if you have perforated your membrane and you have had your augmentation material in the sinus and like a hill, it's going everywhere, then you're sure, even on your X-ray, that you perforated the membrane. But then I think we'll have a because your material, your augmentation material into the prepared sinus shows you or the amount of filling material you need and you can bring in shows you if there is a hole or not. But then it's too late, I would say, because you're creating infections. So these colored pictures show you it's a very small entrance and it's very easy to perform from this point. of you. Okay, so what causes the difficulties? What causes traumatism? I'll give you an answer until now. Well, on the external sinus lift side, it's very easy. Flat-based surgical approach. Drilling of the bone for creating the lateral window, that's very easy, you're very invasive. Replacing the sinus membrane is very invasive. Sometimes you won't see very good. I mentioned at the beginning of the lecture that for me it's very difficult sometimes at the mesial side, at the premolar side, just if you created your window, just to open it, because you won't see there. You just have to feel if with your instrument, with your elevation instrument, if you are underneath the membrane or not. Well, a perfect control mechanism is let the patient breathe. And if there is no perforation, the elevated membrane will move in the rhythm of the breathing. Then you're sure that there is no perforation, but you're not able to do this with the internal sinus. Well, drilling the drain, drilling the hole for the balloon, for the augmentation material, for the hydraulic solution, you have to do this. Fracture of the bony sinus floor, as I mentioned already. If you fracture with the osteotomy technique the last part of the bone, then you might be able to cut little holes into the membrane. Replacing the sinus floor membrane, well, we will see later on in the view of in the literature that it's very clearly how power or how many pressure can the membrane handle. And well, a safe first entry, as I already mentioned, into the sinus without perforation and controlled replacing of the membrane is your criteria for success, I would say. So let's go to the literature, as I already mentioned. Well, mechanical properties. There are some interesting studies about mechanical properties for the Schneider. 132.6% of its original size in one-dimensional elongation. Well, that's much. Or 124.7% in two-dimensional elongation. Well, that means it's very important with the healthy membrane. So this is important for your X-ray before the operation to see, to have an estimation if there is a healthy 1 millimeter thick membrane or not. While unhealthy membranes, they start with a thickness of 3 millimeters. But it's a lot of, and if you see thicker membranes demonstrate significantly higher load limits, then you see it's better to treat a healthy patient than to treat somebody with chronic disease and very thick membranes. Well, a second look into the literature is risk factors of membrane perforation. This is very interesting. I will show you some articles now, because it's very interesting for us to know. And the presence of sinus septa and residual bone height less than 3.5 millimeters are the main risk factors. As I already mentioned we need more than 4. We need 5 millimeter at least as a residual bone height, as I already mentioned, because then we reduce the risk factors as we see in the study, and we want to have these heights to bring in our implant with primary stability. So this is millimeter, 1.5 millimeter residual bone height. Then I think every technique you will use is risky. Often we have to do this, then we will perform the external window, because we're not able to handle this with 1 millimeter with the internal sinus floor techniques. To be honest, sometimes we need the external window, but most we don't need it. So this is very interesting. So it gives us a hint: sinus septa, residual bone height less than 3.5 millimeters. Well, perforation of the sinus elevation study, and we see that the present study failed to demonstrate any factor that statistically significantly increased the risk of sinus membrane perforation. So this is very important to see, because now you will see why the study, why have a look on detail, smokers versus non-smokers, simultaneous versus staged approach, or mixed premolar molar sites versus premolar only sites versus molar only sites, presence of septa versus non-septa. There are always some risk percentage, and they are differing very much. And this study showed us smokers are a problem. We know that septums are problems, but we can't give you something like a cookbook to say, well, this is a patient classification ABC, and this is important for you too, having or reminding you again for the X-ray, for the cone beam diagnostic, which is very about the operation side you will treat. So the best information for you will give you the cone beam then. This is a very simple hint I can give you. So what's the consistency? We talked about different methods, we talked about the dangers, we talked about the problems, we talked about the possibilities, we talked about the anatomy. So what's the consistency now? Well, we want to achieve a high augmentation height, we want to be less invasive, so we need something. And I will show you now what do we need or what you can use. So these are 4 parameters: minimal invasive, safe first contact, height of the lifted membrane, and the feedback system you have to achieve, you have to gain. So this is very easy. We're using now a new method. So if you have to look on this case, it's cone beam picture 2. So you see this is the molar side. We have enough residual bone, but we need something more to put the implant in. Then it's very easy. Just drill your hole, your chamber into the bone until around 1.5 millimeters underneath the bone. Just stop, because you're creating a chamber. And if we're talking about placing an implant at the same time of the sinus floor elevation, then you're creating this chamber at the position of the planned implant. Then we combine our drill with a special pump. And now we combine the pressure of the liquid with the drill. How does it work? Very easily. We just now bring in the pump and the drill, and we close the, if you see the setting of the pump, it's tight on the gingiva, it's tight on the bone, and you can create a closed room where you can bring in now the liquid, and this will be creating a pressure, because for the liquid there's no way to go. And you see now, if we have this chamber under pressure, then we will start with a burr to go forward in the direction of the sinus. And if we perforate the bone just a little bit with a special burr, then by the pressure, the liquid will go into the sinus underneath the membrane. And now we have a perfect way to lift the membrane, because we don't lift it by instrument, we don't lift it by balloons, we will lift it by liquid. And it's very easy, because it will spread out very easily, and it will lift the membrane without any traumatization. And at first we will create something like a hill, and then it will flatten up, and we will reach something like that, because it works by the physical laws of Pascal. That means if you have a balloon and you have several entrances or exits, the pressure will be divided at the same time at every entrance at every exit you have. So this will create a pressure which is on every side the same of the membrane, and to have an easier removal from the membrane, from the Schneiderian membrane from the bone, this liquid will be oscillated. It's not at once, it's oscillated, and then you can remove the membrane. Well, this is the picture from the treatment later on. You see the amount of bone, you see the implant, and you see that we lift it until the palatable side. Well, there's bone everywhere around the implant. So, drilling now to the bone and pressure sealed positioning of the so-called Jeder drill, pressure build up to 1.5 bar, and oscillation is very important. And then now you can slowly, at the time of a minimal perforation, water will go everywhere. And this is very easy. You will use the steroids. Nothing that you have to go with the drill into the sinus. Just open this little hole and the water will go in there. You don't have to drill into the sinus. This is very important. As I mentioned already, never touch the sinus with an instrument. After perforation of the residual crestal bone elevation, the membrane by the oscillating sterile saline will be pushed up by the principle of Pascal, as I already mentioned. Now you're creating a space for the augmentation material. It's a tension-free elevated membrane because you won't use any instrument. You won't use a balloon with a peak of the pressure of the tension at his top. Well, it's a liquid, yeah, and it's very easy. And well, afterwards you can bring back the used amount of liquid of sterile saline solution. You can exhaust it, and then you can see is it the same amount of solution I used to go into the sinus, of the same amount, and then you can calculate what it works very good. This is the first intraoperative feedback system. It's a very easy system, but now you can see, well, it's the same amount of liquid I have before and afterwards, so there should be no perforation. Well, a short example, you see we lifted mesial, and you see that it's like a hill-shaped augmentation we reached. In this case, small, this is nearly 3.0 millimeters residual bone height, and we can augment it. And for this technique, you always have the shape of a hill of the augmentation. You see it works very fine with the augmentation. The same, the bone shrinks more and more after extraction because we have, before extraction, we had the periodontal problems. Bone shrinks, bone disappears, extraction, there's more bone to lose, and then we will bring in the implant, and you see the hill-shaped augmentation. So, short view into the literature that you see it's not eminence-based, it's well-based. We had a study about this, a pilot study for this technique, and we saw that the pump generates hydraulic pressure, as I already told you, 1.5 bar. You push back the membrane, and then you bring in the augmentation material. And as I mentioned before, the problem for the internal sinus lift is having not gained enough height for the augmentation. Now you see the height gain of 9.2 millimeters is very good. So we often have to ask, how much height do I have, or do I have to reach? If we measure, we have 4 or 5 millimeters or 3 millimeters residual bone, then you have to calculate the height you want to gain. So if you have 5 and you gain 9 and you're on 14 millimeters of bone, what length you want to use? Most time we use something like 10 millimeters, 11 millimeters. So you can calculate the height you want to reach. So other studies showed us that the technique combines the advantages of large amounts and the reduced trauma. So we combine a little bit the external window and some of the osteotome technique. We combine the pros and hopefully not the cons for this technique. So in this case, you all see that if there are not more than 3 transcrustal approach, we find very good results for this technique. This is always very important to have a look into the literature, what will give us a literature as information. There you have what I already mentioned. The technique successfully combines advantages of the KaVo look window approach, which permits the placement of high bone graft volumes and the simplicity of the osteotome technique. This means it should be easy in your hand. It should be predictable and it should be successful. This is very important for the internal sinus flow elevation. So controlling during the internal sinus list. I already mentioned the amount of liquid you're using before and afterwards. If it's the same, then you have no perforation of the membrane. Well, in general, we have the direct view. We have the endoscopy. We have a movement of the membrane, as I already mentioned. We have an intraoperative X-ray with the problems I showed you with the soft tissue. And we have the monitoring by really good for us. Well, the direct view is invasive. The endoscopy, we've performed some of endoscopic sinus floor elevations. It's okay, but it's a special instrument. It's a question of cost, and you need a second entrance for the endoscope because you have to look from the top to the left. So you're creating a second wound for the patient. The direct view, the movement of the membrane needs a direct view, so it's nothing for the internal sinus floor elevation. Feasibility and soft tissue means the intraoperative X-ray doesn't show you soft tissue at all. And the monitoring, if you see something on a computer, if you see something on a display, this will be minimal invasive. So at the end, with a big picture, we create where the liquid can go with high pressure oscillating underneath the membrane and can lift the membrane very easily. This is a good way of creating big space. And so if you say, well, I need more than just one implant, you can easily perform the same thing 1 or 2 tooth regions behind or in front of the first entrance. Well, if you create the first bird chamber in the bone and you bring in the liquid and you're creating a pressure, you see that the pressure, that's the blue curve, will increase. And then, because the chamber is full now and the pressure stays stable. And then if you burr forward to the sinus and if you open it a little bit, the pressure will disappear completely, and this is why the curve will go down, because the liquid will now go underneath the membrane. There will be no pressure anymore. There will be more pressure. You see the small mountains, then between more liquid. Then you will create a little bit, increasing the pressure, because the membrane gives to the liquid, but then you will elevate the membrane and the pressure will go down because the membrane will be lifted. This is a perfect control mechanism during the operation. If you look at the curve of the pressure, then you know you have pressure, the pressure will disappear, you know now it's lifted, and if you bring back all the liquid you used, and you can see it, because with the perforation of the membrane, the liquid will disappear too, and the pressure will disappear too. But at the moment you get your liquid back, you use that the membrane is lifted without any perforation, and this is what I call a feedback system. So you see now a picture of on the right of the diagram you have on the pump. It's a permanent measuring of the pressure you always see available of the liquid. We will start with 5.0 milliliters of liquid, and then you see how many liquid you use normally to lift something, to lift the sinus flow to gain 6-7 millimeters in height. We always use 5 milliliters at all. This is enough because you will lift it without any pressure or traumatization to the membrane. So you don't 5.0 milliliters into the membranes. That is just to have something. After the perforation of the bone, or the bone, you see the elevation of the membrane. You can see it on the slide, and you can bring back your solution. So, sorry, I was a little bit too quick. This is what you see. This is what you will have. And the most important thing for me is that everything will be documented. It's not only your feeling you can write down. It's something you have in the computer. It's something you can print. It's something you can give the KaVo. We've been very successful with the lift. So I hope it was not too quick, my ride and my English to this presentation. Now we're at the point of questions and discussions. So, perfect. Let me see the questions. We see. Well, first question. Let me start. When you release the pressure, won't the sinus membrane come back to the normal position? This is a very good question. I forgot to tell you something about this. Sure, if you bring in the water and you bring it back, if you pump it back, the membrane will not really collapse, but it will come back to its old position. This is right. So if you bring now in then the augmentation material, not to start from the beginning again, we don't bring everything from the liquid back from the sinus. There is still some liquid remaining in the sinus. This is why we're using the saline solution, and that we have a small hill. It's easier to bring in the augmentation material then, and to augment the completely sinus we want to augment. So this is right. We don't bring out every water we use. We just leave a little bit in to have a little space and then to bring in the augmentation material. The pressure for the water, you saw it was 1.5. It's something given by the so-called Jederpumpe. Everything is given by this by the pump, and you're not able to change these datas. It's given and it's tested, and it's 1.5, and it's very, very controlled. And you're not pumping as much as you like. There are small portions you can pump in, and then you can pump the next portion. It's not pumping all the 5.0 milliliters you have. I hope this is an answer to the question. And now we have the next questions. You commented that as the lift procedure progresses, the pressure will decrease. Yeah, if the pressure decreases, how does the sinus membrane continue to be lifted? Yeah, it's very easy, because it decreases because the membrane is not as tight on the bone anymore. So you lifted more areas, then it flattens. This is the reason why first it's a hill and then it flattens. And then you have to bring more liquid into the sinus to lift this a little bit more. I told you we use 1.8 milliliter of saline solution to lift it very high. This is the reason we won't give the whole saline solution into the sinus. This is quite enough, because if you imagine you have if you cut visually, if you cut the bone in the sinus, and you see this is the sinus, and this is the buccal, this is the palatal side, and this is the bottom, this is the coronal side, and you bring in the water, it will lift like this, and you will gain a lot of height by using 1.8 milliliter. And if you turn around now and you see like this on the width, you can lift it like this with 1.8 milliliter. It's just enough. Well, perfect. Now more questions. What is the risk of the pressure increasing out of control and rupturing the membrane? Well, that's true. There's no therapy without any problems. Well, the risk of rupturing the membrane, well, depends. At first, it depends on the membrane itself. Well, some membrane, you know this, if you perform an external sinus flow elevation, some membranes are very, very difficult to lift. And even if you have a look on them, they're perforating. So it's always a question of the membrane, of the health state of the membrane too. The pressure is not the problem, because we have a pressure on a very short period of time. We have an oscillating liquid, and we have just a small amount of liquid coming in. It's not 5.0 milliliters at one time. This is very important to know. But to be honest, there are some problems sometimes, but we made a study, and we saw that there was just a small part of the patients we treated had a rupture, and was the number of rupturing was very, very low. And it can happen, no question about, but it's less than if you use a balloon, if you use the osteotome, or if you use the conventional external entrance. Well, what is the risk of perforation at the initial penetration of the drill? Would not the pressure be very high at the initial entrance and create pressure washers kind of results tearing the membrane? Well, the risk is very, very low, because if you have a look on the drill, it's very small, and you just creating a small spot, and then the water will go everywhere. And the risk of the initial entrance of the water, well, it's Pascal showed us in his physical things that the water will spread not in one direction, it's spread in every direction. And this is the difference between the water and the balloon. The balloon just spreads in this direction, and the water will spread in every direction where the water can go. And sometimes there is more resistance of the membrane that on one part of the sinus floor than on the other. And in this case, or for this case, we let the saline solution oscillate. So this can move the membrane better than without any oscillation, and the water will go everywhere. It's not a peak of pressure, it's everywhere, the water. Once the initial lift is completed, at what point do you go ahead and enlarge the site to accept the implant? Well, that's good. That's a good question. At first, I have to be sure that the lift is completed, so that I have my 1.8 millimeter of saline solution into the sinus and I got it back. And then it's always a question. If you do the implant operation at the same time with the augmentation, then you have to enlarge the hole for the implant. And then if you drill the hole for the implant, don't touch the sinus with this burr. You have to know the residual height of your bone, and this will be the length of drilling for the implant. Depends a little bit on the implant you're using. If you're using a root-shaped implant, or if you're using a parallel implant, depends a little bit. And then we drill, and then first we will bring in the augmentation material before we bring in the implant, because the augmentation material should spread out before the implant comes in. Once the initial lift is completed, at what point do you go ahead and enlarge it? We had it already. Can you elaborate on the option of bone augmentation materials? Well, that's a difficult question. I know normally if we have a lecture on this, people ask me always, and we had some slides before. Well, it's kind of question of, it's kind of religion question, I would say. What you prefer or what you learned in your education. Well, we see the gold standard is the bone of the patient, I would say. But today, for sinus floor elevation, there is no use in collecting the bone of the patient from the mandible or from the hip. Today, we can use some other materials. My preferred material is xenograph. Means this is the best thing we can use, because we have to be sure about the resorption of the material. We have to be sure about the transformation from graft to the bone of the patient, that this can take place. We use xenografts, yes. Augmentation for this specific techniques, sorry. Well, Mike, I'm not sure about this question. Augmentation for this specific technique. Okay. I think you will ask if there's a special material for this technique. No, there's no special material. You can use any implant. You can use your home implant system you use today, and you can use any augmentation material you want, because it's a lift. At the end of the day, it's a lift, and it's just another way to the lift, but it's a lift. And then if you have lifted your membrane, you can bring in every material you can bring in through this entrance you created. And if you augmented until today with a balloon, you had nearly the same size of entrance and you brought in the material, you can use the same material. It's no problem. It's no change in material. It's no change in implant systems. I hope I got them all, the questions. Well, the first is a link to the presentation. I'm not sure. We have to talk to Dental Tribune. The diameter of the drill I use, yeah, it's very small. It's 1.2 at the beginning. It's very, very small. And then you're spreading up. But you use the drill given you by this YEDA system, because it's well calculated. They have their own drills. And the first drill you use by your choice would be the drill for the implant. Because as I already mentioned, the YEDA system is not related to any implant system. So if you bring in your implant, you have to create the hole for the implant by yourself, by your implant system, and then you can use your own drills. But this is at a stage where you have already augmented and lifted the sinus floor. I hope this is explained good for you. Sometimes that's so easy. Okay, perfect. Now let me read if there are some questions. When you back, we had this already. Pressure of the water we had. So I think should be clear now for this hour short lecture for the internal sinus floor elevation. Perfect.
Thank you very much, Dr. Engelschalk, for sharing your lecture and your insightful information with us. We would also like to thank KaVo Academy for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERB CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions for Dr. Engelschalk may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Engelschalk will be sure to get back to you as soon as possible. Please be sure to visit the Dental Tribune Study Club educational platform www.dtstudyclub.com and keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.